Hello and welcome. My name is Brianne Murchie. I sometimes go by Miss Bree. If you are not familiar with who I am the clinical coordinator for the surgical tech program at Rasmussen University at the Romeoville Juliet campus. We're going to get started today on the very first certification review session that will get you guys prepared to take the NBS-TSA certification exam. So first thing I'm going to do is share my screen. Okay, let's blow this up. Okay, so each certification review session is going to be roughly about 30 to 45 minutes. The video will be posted each week on Blackboard that an online certification review session is held, and you will have access to this video. You can play it as many times as you like. For your information, the access code for the path points for the online certification review sessions will be hidden somewhere in the stack that I'm going to be presenting here today, and it'll be in a different place every single time. So please, please watch the recording in its entirety, follow along with me. This is for your own good, so you get enough review for the certification exam, so you'll be prepared. Okay, so the first thing I hope that you do for me is you're going to find the packet that accompanies this certification review session. It's going to look like this. Can you guys see that? Okay, fantastic. So on the front, it says do not complete until certification review session, and then whatever number we're on. And to find that, you're going to go on Blackboard. So on Blackboard, under the Student Resources folder, in the Certification Review Sessions folder, you will find our very first packet, which is Cert Review Questions for Session 1. So please download that, print it out. I prefer the printout version. If you're more comfortable doing the questions on a tablet or on a computer separate from this video, that is fine, but please have them available because you're going to need them. Before we actually get started with the review topics today, I wanted to quickly talk about the NBS-TSA certification exam and what you're going to see on that exam and how we're going to prepare. So the exam is 4 hours. I've never had anyone take 4 hours, but you get 4 hours for the exam, and it is 175 questions in total. 150 of those 175 questions are scored. 25 are considered unscored pre-test items. So you will only need a 98 out of 150 to pass certification. That roughly translates to a 65.33%. And this is the breakdown. There are 3 categories and subcategories within. So the first category is preoperative care. That is the largest amount of questions that you will see. There are going to be 19 items in preoperative preparation, 68 in intraoperative procedures, and 10 in postoperative procedures. Intraoperative procedures, as you know, is going to be the most time that we have as surgical techs, so that's why it is the largest amount of questions you will see on the exam. The second category is going to be ancillary duties. 7 of those are going to be administrative and personnel questions, and 16 are going to be equipment, sterilization, and maintenance. So please review your equipment sterilization chapter in Fuller's textbook. It is chapter 10. I believe it's decontamination, disinfection, sterilization. That is going to be the largest section out of that category. And the last category is going to be our basic sciences category. The largest section you'll see out of there is going to be anatomy and physiology. That's going to be 18 questions. And then you'll see 6 questions each for microbiology and surgical pharmacology. If you are interested in going to the NBS-TSA certification website, I have the link for you here, nbstsa.org/CST exam prep. You will find the breakdown for the certification exam, what to expect, what to bring for your certification exam, and test taking strategies and study resources. Okay. This is something that I take very seriously. I think test taking strategies should be an integral part of preparing for the certification exam. So I'm going to briefly discuss my kind of top 4 tips for taking a multiple choice exam. And you have to follow it step by step. So it's relatively simple. I feel that a lot of people do this without even realizing it. But if you are someone that struggles with test taking anxiety, or you're not exactly sure how to get the most optimal grade on your exams, following these steps is going to greatly improve your scores. So follow along with me. Number 1 is really simple. Read the question in its entirety. I know I am someone who tends to want to get it over with and speed through. You get 4 hours for this exam. There's no additional credit if you take it in 30 minutes or 4 hours. Take your time, okay? So read the question in its entirety, close your eyes, take a deep breath, digest it, okay? Do not immediately look at A, B, C, and D. Wait a minute, breathe. Think it through and try to answer it in your head before you actually look at A, B, C, and D. That's going to come in clutch later. Okay, so read the question, close your eyes and take a deep breath. Try to answer it on your own before you look at A, B, C, and D. My second step is to read it one more time. I know we can read, but sometimes we go really fast and we miss key words. You need to know them. Okay, so read the question once more. Make sure you understand exactly what the question is asking. Remember to identify those keywords. Some of those questions are going to say, all of these are true except, or all of these are true but. Make sure you identify which one of these is true or which one of these is false. And there are going to be questions where the language states which is the best option or which is the most ideal option or which is best practice, because maybe A, B, C, and D, maybe a few of those answers are true. So you need to find the most ideal or kind of book versus reality. You need to go by the book. Whatever you saw in clinicals, I'm sure was really helpful. But if what you saw in clinicals differs from the book, go with the textbook. That is what you need to make sure you remember. Keep that in the front of your head, of your mind. Okay, so you read the question once, you took a deep breath, you digested it, you answered it in your head, read it once more, and then make sure you identify any of the keywords. Third step is to eliminate 2 options. Process of elimination, doing this 50-50 strategy, is going to get you the most ideal chance of answering the question correctly. So whatever process you need to do to eliminate 2 of the options, scratch 2 of them off the board and then focus on the last 2 left. Okay, the most ideal answers for the question. Get it down to a 2, okay? Because you don't want a 25% chance of getting it right if you keep all 4. You want a 50% chance of getting it right. So it'll greatly improve your odds. And then the last step is answer your question with confidence, okay? You've already done the first 3 steps. This is going to make or break how you perform on this test. Confidence is key. Okay, so if the answer that you had in your head from step 1 matches one of your options in your 50-50, go with that. Okay, if you didn't know what the answer was, if you couldn't answer it in your head and you have it down to a 50-50, make your best educated guess. Okay, this is where it gets tricky for some people. Do not go back and change your answer. Go with your gut. I mean it. A lot of people kick themselves for having it right the first time and then going back and changing their answer. So the only exception for you changing your answer ever, ever, ever is if you realize you misunderstood the question, or say a little later through the exam, you get another question that's kind of similar and it helps to jog your memory. It reminded you of something from clinical or from class or your textbook, and you have an aha moment. Then you can go back, reassess, still do the test taking strategies again, but take what you got from that memory and apply it, okay? But I don't want you going back and changing every answer because you're second guessing yourself. Confidence is key. Okay. These are going to be our learning objectives for today. We're going to talk about general surgery in depth. We're going to have 15 questions on anatomy and physiology, 15 questions on intraoperative procedures. And then we're going to have a third category. We're going to do some microbiology review as well. Okay. For the general surgery A and P review, we are going to, as a group, me and you, we're going to do those test taking strategies together for question number 1, and then you're going to do this on your own. Okay, so for number 1, and you can take your packet and flip to the first page and read number 1 with me. Number 1, which physiological mechanism assists in propelling food along the gastrointestinal tract? I'm going to stop the presentation. I'm going to blow it up here so we can actually do our test taking strategies. Hopefully you guys can still see this. Okay, so we're looking for a physiological mechanism. I'm going to stop right there and start to pick that apart. What does physiological mean? It has to do with the body, okay? The mechanisms within the body that help us work, okay, as a human being. And we're talking about propelling food along the gastrointestinal tract. When we talk about propelling food, I'm wondering, even if gravity isn't playing a factor, if I'm laying down, how is food moving through my GI tract? I want to know there's an actual mechanism within my body that's helping to move that along. And I'm going to pick apart what the gastrointestinal tract means. Gastrointestinal tract, in my loving definition, I like to call this the food tube. Some people call this the alimentary canal, alimentary meaning food. So what is the food tube? We start with the mouth. Obviously, we're going to chew and swallow the food. Then the food is going to travel down the esophagus, which is going to transport that food from our mouth to our stomach. Okay, so once the food enters our stomach, the food will churn and be propelled into the small intestines. It's first going to enter the duodenum, and then the jejunum, and then the ileum. Once it goes through the small intestine, we're going to enter the large intestine. It starts at the cecum, and then it's going to travel up the ascending colon. It's going to make a turn at the hepatic flexure into the transverse colon. It's going to make another turn along the splenic flexure to the descending colon. It's going to make a little S curve through the sigmoid colon, and then it's going to be stored in the rectum until we're going to eliminate it through the anus. So that is the gastrointestinal tract in a nutshell. Okay, so we're looking for how the food is going to move through that tract. Our options. I'm going to take a deep breath. Maybe I don't know it. Okay, that's okay. I'm going to read it again, make sure that I understand which physiological mechanism assists in propelling food along the gastrointestinal tract. So I'm looking for the best possible answer of what system in my body or what mechanism in my body or anyone else's body moves that food from mouth all the way through esophagus, stomach, small intestine, and large intestine out through the anal orifice. How is that food moving? So our options: defecation, mastication, micturition, and peristalsis. Well, I know for a fact that the word defecation means pooping. We all know that. And that does move food. However, it doesn't move the food along the gastrointestinal tract. I know that it moves the food out of the body, out of the gastrointestinal tract. So that doesn't quite align with what we're looking for. So I'm going to get rid of it. That is going to be one of my eliminations. Okay. The other 3 options: mastication, micturition, peristalsis. I remember this is me. Maybe it's not you. That's okay. This is my process. The word mastication, I think of the masseter muscles in my cheeks, and those masseter muscles are helpful in the process of chewing. Okay, so the process of chewing only breaks down the food physically with our teeth and the chemicals in the saliva. It's not going to physically help propel the food along the gastrointestinal tract. It'll help break down the food, but it's not moving that food at all. So I'm going to get rid of mastication. So I have a 50-50 chance now. So I've eliminated A and B, and I have C and D left. Based on what I know, and we're going from what I remember in class, what I remember from the textbook, what I remember from studying, what I remember from being at clinicals. The word peri means to surround or around. And I know the food tube is a tube, right? So I know based on the idea of gravity is not going to play all of a part, but it's going to play some of a part, but we need another mechanism along with gravity to help move that food along. We're looking for a muscle, like a tubular muscle that's going to help squeeze that food through the tube. So because the word peri is in the word peristalsis and micturition, maybe you're not super familiar with the word micturition. I know what it is because I'm the teacher, but based on my knowledge of medical terminology, this is probably my best option. So I'm going to go with the word peristalsis for my answer. I'm going to show you that I'm obviously right because I did my test taking strategies, A, B, C, and D. So this is what peristalsis means. Peri means surrounding or around, and stalsis means contraction. So if you can see in this image, actually, I'm going to move my body this way so you guys can see. The bolus of food is going to go through the esophagus by this act of contracting. Okay, sorry, my head's in the way, but the actual food is going to move through the gastrointestinal tract through this squeezing of the muscles. Make sense? Hopefully it does. Okay. If anyone was wondering, the word micturition is the medical term for peeing or urination. Okay. Come on. There we go. Okay, so this is where you guys come in. You are going to answer the rest of the general surgery, anatomy, and physiology review numbers 12 through 15 using those strategies. So when I say pause, please hit the pause button on your video player and answer numbers 2 through 15 on your own. When you've completed 2 through 15, you may hit play and continue watching. We'll review the answers together when the video resumes. On the count of 3, 1, 2, 3. Pause. Welcome back. Okay, we're going to go through all these answers together as a group. Okay, so which of the following wound complications is the formation of an abnormal tract or a tunnel between two body parts that has two distinct openings? I know that it's not a hernia, and I know it's not an abscess. That is my 50-50. An abscess is like a festering wound that makes pus, can be underneath the skin, it can open. It can make one of these tunnelings, but it's not actually a tunnel yet. And then a hernia is a weakness in a wall that allows a structure to kind of bulge through that wall where it's not supposed to. So it could be an abdominal wall hernia, a vaginal vault hernia, a diaphragmatic hernia. There's a lot of options, but it's not a tunnel. Okay, so I'm between fistula and sinus. The answer here is fistula. And this is the difference. A sinus has one opening, fistula has two. My funny little way of remembering this is I have two fists, a fistula has two openings. Okay, which abdominal organ is located in the right upper quadrant? Now, I want you to use your own body. That's the only thing you can bring into this exam is your own body. So I'm going to poke around in my right upper quadrant and figure out what might be over there. So the options are appendix, gallbladder, sigmoid colon, and spleen. And we talked about the gastrointestinal tract a little bit. So we talked about the beginning of the gastrointestinal tract is the cecum, which is in the bottom right quadrant. That's going to have the appendix attached to it. So appendix is gone for me. The other part of the large intestine that we talked about are the flexures. We have the hepatic flexure on the right, splenic flexure on the left. Splenic means spleen. So if the splenic flexure is on the left, spleen is also on the left. So the spleen is going to be eliminated as well. So my last two options are gallbladder and sigmoid colon. I know hepatic flexure on the top right, the upper right, excuse me. Hepatic means liver, and the gallbladder is right underneath the liver. So that is going to be our answer here in the right upper quadrant is gallbladder. Okay, number 4. Which muscle is not part of the abdominal wall? Again, I'm going to take a deep breath. I'm going to close my eyes, not part of the abdominal wall. I'm going to read it again. I understand that because the question is saying which muscle is not part of the abdominal wall, 3 of them are going to be in the abdominal wall. There's only going to be one that's not. So make sure you didn't read that question too quickly. Okay, so we've got external oblique, rectus abdominis, transverse rectus, and vastus lateralis. So I know the word abdominis means abdomen. So rectus abdominis is going to be one of my eliminated answers because I know for a fact that's in the abdominal wall. And then transverse rectus, I know for a fact is also in the abdominal wall because I remembered from studying for general surgery that the transverse rectus, just like the rectus abdominis, is part of the abdominal wall. So my two options are A and D, external oblique and vastus lateralis. Now I remember from our talks about general surgery and orthopedic surgery that the external obliques are the outermost muscle in the abdominal wall. And vastus lateralis is starting to look really suspicious. It's not part of the abdominal wall. I'm starting to remember it is one of the 4 quadriceps muscles. So that's going to be our answer. Vastus lateralis is not part of the abdominal wall. It's actually part of the quad. Okay, which structure serves as a point of attachment between the intestines and the posterior abdominal wall? I'm going to go through these answers a little bit quicker because we've already talked about the test taking strategies at length. So I don't want to bore you, okay? But hopefully you have already gotten to a 50-50. My 50-50 would be A and D, linea alba and Scarpa's fascia. Our answer, oh my gosh, I'm sorry. My brain is a little broken. I'm thinking of the line. See, I should have done my test taking strategies. This should be a lesson to you guys. I'm going to do it. Okay, which structure serves as the point of attachment between the intestines and the posterior abdominal wall? My brain was reading what's the line connecting the anterior abdominal wall, which would be the linea alba. That's not what the question's asking, Miss Bree. Okay, which structure serves as the point of attachment between the intestines and the posterior abdominal wall? Okay, well, I know linea alba is not it because the linea alba holds the rectus abdominis muscles together in the anterior abdominal wall. So linea alba is out. And then Scarpa's fascia is also going to be the fascia that lines some of the external abdominal wall muscles, especially in the lower abdominal pelvic region. So Scarpa's fascia is also gone. So we're down to mesentery and omentum. That should be my 50-50. Here we go. And then our answer here is going to be the mesentery. And you can see I've attached some images here. This kind of, the best explanation I can give, it's almost like yellow. That's the best color I've got. Yellow, and you can see that it is lined with vessels, blood vessels. That segment right here that's attaching to the intestines, that yellow tissue with blood vessels running through it is the mesentery. Those blood vessels are mesenteric arteries. And you can see here in the illustration that the mesentery is actually going to connect to, it's a reflection of the abdominal peritoneum, and its job is to hold the intestines in place. So when we are moving around, the intestines don't tie itself in knots. That's essentially part of what the mesentery does, helps to keep the intestines in place so they don't get twisted up. And then the other biggest role of the mesentery is to provide blood vessels and nerves to the intestines. Good. Okay, Which anatomical landmark is bounded by the cystic duct, the common hepatic duct, and the inferior surface of the liver? So I know that the cubital tunnel, if you remember from orthopedic surgery or neurosurgery, the cubital tunnel is here in the elbow, and we would do an ulnar nerve release. So that's going to be gone because we're looking for something that's around the cystic duct, the common hepatic duct, and the inferior surface of the liver, and that's in the abdomen. So I know cubital tunnel is gone. And then the other one I'm going to eliminate the trigone. The trigone is a triangle within the urinary bladder that is an anatomical landmark between the two openings of the ureters and then the opening of the urethra. It inside the bladder, it makes a little triangle. So that's what the trigone is. So in my mind, trigone is also out. So B and C are left. My answer here is going to be the triangle of Collat, because I know that the triangle of Collat is used to identify the cystic artery when we're doing a cholecystectomy, which is a gallbladder removal. Hesselbeck's triangle, another triangle in general surgery territory. Hesselbeck's triangle has to do with a direct inguinal hernia. So that's a different triangle. Don't get them confused. Which of the following abdominal organs is responsible for producing insulin? Well, let me see if I remember. I know that the cells for producing insulin are found, see, I'm not even going to look at A, B, C, and D, are found in the pancreas. So let me take a deep breath, look at the question again. Which of the following abdominal organs is responsible for producing insulin? Okay, so my best guess is the pancreas. Let's see if it's out there. So we've got gallbladder, liver, pancreas, and spleen. Now, I know a lot of you are going to say, well, you know it's pancreas. Answer it and move on. I want to make sure. I want to be darn sure that nothing else out there is a possible option. So I'm still going to do my 50-50. So I've got gallbladder, liver, pancreas, and spleen. I'm going to keep pancreas on the board. I'm going to remove liver because I know that the liver produces bile, right? I know that that's the liver's job, is to produce bile. So liver's gone. And then the gallbladder is right underneath the liver. I sometimes call the gallbladder the liver's little like bile purse, because that's what it is. The gallbladder stores the bile produced by the liver and uses it every time we eat food. So A and B are gone. So I've got pancreas and spleen, and I'm going with my gut that it's pancreas, and I am right. The pancreas is going to be our answer here. The spleen does not produce insulin whatsoever. Spleen has no business in that realm, so I'm glad that I went with my gut. Okay, so I kind of dropped this earlier. Which of the following cells is responsible for producing insulin? So I remembered that the cells for producing insulin were in the pancreas, and I'm looking for cells responsible for producing insulin inside the pancreas. Okay, so we've got hepatocytes, islets of Langerhans, nephrons, and white pulp. I know the nephrons are in the kidneys. They're not in the pancreas. The nephrons are responsible for making urine in the kidney, so I'm going to get rid of nephrons. Hepatocytes. Well, I know hepato means liver. Hepato is the med term for liver, so I'm going to get rid of hepatocytes as well, because that would be liver cells, not pancreatic cells. So I've got B and D, and my memory of this is that it's the islets of Langerhans, because we talked about that in class. So let's go with that. Yes, islets of Langerhans is going to be our answer here. And you can see the different cells within the pancreas are responsible for producing different hormones and different enzymes. So the beta cells secrete insulin, the alpha cells secrete glucagon, the delta cells secrete somatostatin, and then the F cells are going to be responsible for secreting pancreatic polypeptide. So remember some of this stuff because you might see it come up on certification. Okay, which is the most distal portion of the small intestine? Antrum, duodenum, ileum, jejunum. Okay, I'm looking again. Which is the most distal portion of the small intestine? So I'm thinking distal, proximal is towards midline, Distal's away from midline. So I'm looking for it. With the tube, it's a little bit harder with the GI tube. It's not necessarily the closest or furthest away from midline. It's the beginning and the end of the tube. So I'm looking for the part of the small intestine that is kind of the end section of the small intestine. And I remember there are 3 portions of the small intestine. I remember that because I'm studying hard, and I remember there are 3 sections of the small intestine. The duodenum, the jejunum, and the ileum. I always say DJI. So I'm looking for ileum, right? DJI, distal, the end of the tube. So that would be the ileum. Let's look for it, okay? We've got antrum, duodenum, ileum, and jejunum. I know ileum is what I answered in my head, so I'm going to keep that on the board. I know it's not duodenum and jejunum because I thought about the small intestine. It starts with the duodenum, so it can't be that. The middle section's the jejunum, can't be that. So I have either antrum or ileum, okay? If you're not sure what the antrum is, but you know the ileum's part of the small intestine and you answered that in your head, it's not a trick question. Go with ileum, go with your gut. If you know what you know, go with it. Don't go with something you might not be familiar with. If anyone is interested, the antrum is part of the stomach. So that's why I'm glad that I stuck with my gut. Huh, gut. You like that joke? Okay, which is the most proximal portion of the large intestine? Now we just talked about the most distal portion of the tube being the end. So the most proximal portion of the tube is going to be the beginning. So I'm looking for the beginning of the large intestine. We talked about the large intestine when we talked about the very first question. So it starts with the cecum. So I'm hoping cecum's out there. Cecum is. So we've got ascending colon, cecum, rectum, and sigmoid colon. Now, I'm sure that this says the most proximal portion of the large intestine, so I'm looking for the beginning. So I'm going to keep cecum on my board. Let's get rid of the ones that don't make sense. Rectum doesn't make sense because that's the end of the large intestine. That's where the feces is going to stay put until we're ready for defecation. So rectum's not a good answer, so we're going to get rid of rectum. And then I'm going to get rid of sigmoid colon as well, because I know sigmoid colon, that little S curve, is the last part of the tube before we get to the rectum. So I'm going to get rid of sigmoid colon as well. So my 50-50 is ascending colon and cecum. I know that the cecum comes first. I'm going to stick with that answer, and I'm right. Here's the large intestine here. You can see the cecum and the little appendix attached to it. And there's the ascending colon. Hepatic flexures here. Here's transverse colon, splenic flexures here. Descending colon. Here's my S curve, that's sigmoid colon, and then we'll see rectum and then the exits at the anus. Good. The common bile duct is formed by the joining of which 2 structures? Common bile duct. When I ever hear a tube, a nerve, a vessel that says the word common in it, I think that 2 tubes have something in common. Okay, so I think 2 tubes are going to join together to then form 1 tube. And that 1 tube we're looking at is the common bile duct. So I'm looking for the 2 tubes that have the common bile duct in common. So, and I know the common bile duct is going to hold bile. So I'm looking for stuff that has to do with either the gallbladder or the liver, because we just talked about that earlier. So let's see. We've got common hepatic duct and cystic duct. We have common hepatic duct and pancreatic duct. We have cystic duct and pancreatic duct. And we have the right hepatic duct and the left hepatic duct. Okay, so I'm going to get rid of the ones that say pancreatic, because that is, the pancreatic duct doesn't hold bile. And I'm looking for 2 tubes that both hold bile to form the common bile duct, because that holds bile. Okay, so I'm going to get rid of B and C, because the pancreatic duct sends pancreatic hormones like insulin, glucagon, and pancreatic enzymes. Doesn't hold bile. So I'm going to get rid of B and C. And then we've got A and D. A says common hepatic duct and the cystic duct. And then D says the right hepatic duct and the left hepatic duct. Now I'm thinking of the liver, and the hepatic ducts mean liver, right? So there's the liver, and then the two ducts coming from the right and left lobes of the liver, creating the right hepatic duct on the right, left hepatic duct on the left. Those two obviously are going to have something in common, so that's possible. And then with A, we've got the common hepatic duct, which now that I start to think about that, might be the joining of D. So let's think about it. The common hepatic duct and then the cystic duct. Well, the word cyst means a fluid-filled sac. And to remove the gallbladder is cholecystectomy because cholecysto means the gallbladder. And the gallbladder is a bile-filled sac. So the cystic duct might be a better option. I'm going to go with A because I'm now starting to put two and two together. I think the common hepatic duct is going to be the product of D. The right hepatic duct and the left hepatic duct are going to make the common hepatic duct. So then the common hepatic duct from the liver is going to join with the cystic duct from the gallbladder. And there we go. So if you can see in green, the little branch of the common hepatic duct on the right and left sides, that's the right and left hepatic duct. That makes the common hepatic duct right there. And then the cystic duct comes off of this bile-filled sac, which is why it's called the cystic duct. So that cystic duct is yellow. The common hepatic duct is in green. That's going to make our common bile duct in red. Okay. Then our pancreatic duct is in blue. I'm sorry, my body's in front of it. And then that is going to join the common bile duct here at the ampulla of Vater to inject those fluids, the bile and everything from the pancreas, into the duodenum to help digest our food. Okay, bile is necessary for what physiological function? The absorption of vitamins and minerals, the breakdown of fat, the destruction of aged red blood cells, and the managing of blood sugar. So I know the managing of blood sugar has to do with the pancreas, not the bile, so I'm going to get rid of D, and I'm going to get rid of C. I know that bile has something to do with digestion. I know it doesn't have anything to do with the blood cells. So I'm going to get rid of C and D, and I'm going to stick with A and B as my 50-50. Absorption of vitamins and minerals and the breakdown of fat. I'm pretty certain that the bile helps actually like break down food. Yep. I'm going to go with B. B is probably the best one. Okay. Yep. B is our answer here. Helps with digestion, the absorption of fats. It helps emulsify and solubilize the fat in our food. And then it helps with excretion as well. Sorry, my body's blocking that picture. Okay, metastatic breast tumor would likely drain first to which lymph node? So we're looking for the lymphatic system that connects the breast to the rest of the body. So we have axillary, cervical, sentinel, and supraclavicular. So supraclavicular is above the collarbone. It's really far from the breast. What else is there? Cervical means the neck. Cervical means neck, okay? Even the cervix of the uterus is the neck of the uterus. That's why it's called the cervix. So cervical means neck. So we're talking about the lymph nodes in the neck, and then we've got axillary is armpit, and then sentinel. I know the word sentinel usually means like the primary person. Okay, so I'm going to get rid of B and D because neck and above the collarbone isn't as close as the armpit. And the word sentinel is really ringing a bell, so I'm going to keep that. So I'm going to keep A and C is going to be my answer here. Okay, and that makes the most sense because our sentinel lymph node is going to be the first in the chain, and then it'll go to the axillary lymph nodes, and then it'll go up into the clavicular and the cervical lymph nodes. So that's going to be the traveling path from the tumor in the breast. First node is going to be the sentinel lymph node or first, and then it's going to travel up to the axillary lymph nodes and beyond. Two lobes of the thyroid gland are connected by what central band of tissue? Cooper's ligament, the dentate line, falciform ligament, and isthmus. Well, I did a lot of hemorrhoidectomies in my time, and I know that a lot of the specimens from my surgeon had used the word dentate line in the specimens. So I'm pretty sure dentate line has to do with hemorrhoids or the anus. So I'm going to eliminate B. Cooper's ligament, falciform ligament, isthmus. Isthmus I'm going to keep. That I think is my answer. Falciform ligament I know is the ligament that divides the liver into the right and left lobes. I know that because I studied the liver intensely. So I'm going to get rid of falciform ligament as well. I'm going to keep A and D. I'm pretty certain it's D because I answered that in my head earlier. And that's going to be our answer here. That's what the isthmus looks like. Isthmus is kind of like a band connecting islands. That's like where the word kind of comes from. So that's why I remembered isthmus. I kind of think of like two islands connected by a little bridge, kind of like two islands connected by a bridge of sand in the ocean. So that's the isthmus. That's what it looks like right there. Sometimes there's a little third lobe that comes off of the isthmus, like a pyramidal lobe. Last one. The stomach connects to the small intestine at which anatomical landmark? The ampulla levator, the ligament of Treitz, the lower esophageal sphincter, and the pyloric sphincter. We're talking about the stomach connecting to the small intestine. So where the stomach and the duodenum join. Okay, so let's see. I know it's not the lower esophageal sphincter because the esophagus connects to the stomach at the beginning of the stomach. So I'm going to get rid of lower esophageal sphincter because that's the sphincter between the esophagus and the stomach above. We're looking for the end of the stomach. That's going to connect to the small intestine. Okay, and then the ampulla levator, we just talked about this a little bit. The ampulla levator is where the common bile duct and the pancreatic duct allow those fluids, bile, pancreatic hormones, pancreatic enzymes to the duodenum, but it doesn't have anything to do with the stomach, the ampulla levator. So I'm going to get rid of that as well. So I've got the ligament of Treitz and the pyloric sphincter, B and D. If I remember the stomach correctly, the beginning of the stomach where it meets the esophagus is the cardia. That little bump at the top, like the dome of the stomach, is called the fundus. And then there's the body. And then there's the antrum. And then the pylorus. The pylorus is at the end, I remember. So I'm going to go with pyloric sphincter. And there it is. You can see kind of where all the landmarks are. And the actual pylorus is going to have that pyloric sphincter. That's going to connect the stomach and the duodenum. Okay, so that is anatomy and physiology review. I am taking quite a bit of time, so I'm going to speed things up here. For general surgery, you are going to pause when I say so. Not 2 through 5, 1 through 15, excuse me. When you complete 1 through 15, you can hit play and continue watching. We'll review the answers together when the video resumes. Okay, on the count of 3, you're going to pause. Ready? 1, 2, 3, pause. Okay, welcome back. Hopefully you actually paused and did all the answers. Okay, so we're going to go through these answers very quickly. I'm not going to do the 50-50. But you can go back. The lesson is going to be online. The actual PowerPoint will also be posted for you online, so you can look through the PowerPoint slowly on your own. So let's go through the answers here. Number 1, our answer is B, reverse Trendelenburg. Answer number 2 is going to be A, Coker. Number 3, our answer is going to be D, the T-tube. You can kind of see the picture of the T-tube in use right there. Okay, number 4, our answer is A, the Billroth 1. I remember this because the Billroth 1, we're connecting the stomach to the first part of the small intestine, and the Billroth 2, we're connecting the stomach to the second part of the small intestine. So Billroth 1 is stomach to duodenum, and Billroth 2 is stomach to jejunum, which is the second part. Get it? Okay. Number 5, our answer is going to be, get ready for this, write it down. Our access code for Module 3 PATH certification review session is 844523. Again, 844523. Okay, we're going to resume. The answer for number 5 is C, right? Hemicolectomy. Number 6, our answer is going to be D, a class 4. Okay, and if you can pause here, please, if you have problems with the classifications of wounds, this is a really nice flow chart to identify which class it is. So please review this flow chart. Pause it really quick and review it. It's really, really helpful. It's helped me a ton. Okay, number 7, our answer is D, stage 4 breast cancer. And these are going to be our parameters for identifying the stages of breast cancer. Anytime the breast cancer has gone to a different part of the body, that's going to be stage 4. Number 8, which dye? Answer is C, isosophan blue. You can actually see that it is blue. We're looking for isosophan blue because we're looking for a dye specifically. We are looking for a dye, and that's going to show up as a color. Okay. When performing a thyroidectomy, number 9, we are looking for the answer C, which is tetany. Number 10, our answer is B, an EEA stapler. That's how it works. An EEA means end-to-end anastomosis. Okay, hopefully that helped. Okay, our microbiology review. Again, you're going to answer numbers 1 through 15 using your test taking strategies. When I say pause, hit pause, answer numbers 1 through 15 using our strategies, answer all the micro questions, and then when you've done so, press play on the count of 3. Ready? 1, 2, 3, pause. Welcome back. Okay, number 1, our answer for gross debris accumulated on the surface of an inanimate object. That's our bioburden. You can kind of see the picture of that really gross bioburden on the end of that. It's either a laparoscopic or a robotic. Actually, it looks robotic. Scissor. Number 2, our answer is A, antisepsis, because we're talking about the skin. The skin cannot be disinfected. That's for inanimate objects. The skin cannot be sterilized because it's a living organism, because we have residential flora. Okay, we have microbes that live within our skin that cannot be removed if the person's alive. So we're looking at A is the best answer because anti is against, and then sepsis is the microbes that cause infection. So we are looking for antisepsis. Number 3, the answer is prions. Prions are, trying to remember the exact language. I believe they are called proteinaceous protein particles, I believe, but they're not a virus, they're not a bacteria. They are just a strand of protein that can cause spongiform encephalitis. That's what Creutzfeldt-Jakob is called. It's also, prions can cause mad cow disease in cows and scarpy in sheep. So there's different spongiform encephalitis for different organisms, like mammals. So in humans, it's called Creutzfeldt-Jacob's disease. Number 4, our answer is B. And please review this chart on your own. Please pause, understand the difference between eukaryotes, which are multiple-celled organisms, and prokaryotes, which are single-celled organisms. Please look through that by yourself. Okay, number 5, which of the following bacterial morphologies is rod-shaped? Our answer is bacillus. Coxoid is spherical or round like a globe. Spirilla is spiral, and then spirochete also is kind of a spiral pattern. So there's spheres, rods, and spirals. Which organism, number 6, is most commonly transmitted pathogen in the OR? It, hands down, it is Staph aureus. That is the most common transmitted pathogen in the OR that leads to surgical site infections because Staph aureus is the most common bacteria that lives on and within the surface of skin. Okay, number 7, our answer, is standard precautions. Basically, the gist of standard precautions is you treat every patient with the exact same precautions regardless of their status, because you might not know what the patient has and they might not know what they have. So you treat everybody the exact same. And this is what standard precautions is all about and how to do it. Hand hygiene, reprocessing, environmental cleaning, PPE, all that stuff. Okay, number 8, our answer is 10 hours to submerge glutaraldehyde for sterilization. You only need to submerge an item in glutaraldehyde for 20 minutes to achieve high-level disinfection. But if you want to achieve sterilization, it needs a minimum of 10 hours. Okay, number 9, our answer is surgically clean. Again, disinfection is for inanimate objects. I could disinfect the surface of my table here, but I can't do that to the skin. We're looking for surgically clean. You can't sterilize the skin either. Okay, number 10, tuberculosis is transmitted through coughing or sneezing. We always remember that if a patient has tuberculosis, we're going in with respiratory precautions. So a high filtration mask like an N95 and eye protection and a gown. Okay, so TB is droplet nuclei. Okay, which bacterial species requires the presence of oxygen to survive? That is our obligate aerobes. They need, require means need, the presence of oxygen to survive. So if you notice, the obligate aerobes in this tube of agar or concentration medium is all of those bacteria floated to the top because they need air to breathe. Kind of like if you're swimming in a pool, you need to stay above the water because you need air to breathe. So do obligate aerobes. Okay. And these are other options, other examples of the different types of microbes and their oxygen requirements or lack thereof. So please pause, review this on your own. Obligate aerobes, obligate anaerobes, facultative anaerobes, and aerotolerant anaerobes, excuse me. Number 12, the answer here is commensalism. Please review the differences between mutualism, commensalism, and parasitism. Number 13, our answer here is the nucleus. The nucleus is the center of our cell. That is going to have the genetic material for replication and other major energy needs and resource needs of the cell. I'm starting to get tired. Okay, please review the cell on your own time. Number 14, our answer is D, virus, because it is a non-living particle. And number 15, our answer is B. The reason I remember H. pylori causing stomach ulcers, we talked about it already, the pylorus is the most distal portion of the stomach. So I always think if I see H. pylori, pylorus, stomach. So I associate stomach ulcers. Okay, that is it for me. Sorry that this one took an hour, but we talked a little bit at the beginning. So the next ones will, I promise, be 30 to 45 minutes. But I hope you had a good time reviewing with me. If you need to contact me, this is my contact information, and you can message me through Blackboard as well. Thank you guys so much. I really appreciate you being here with me. Have a great rest of your week. Take care.